Today I have with me Mary Nelson. She's the Medication Diversion Safety Specialist at Honor Health. Welcome, Mary.
Thank you, Terry. Thanks for having me.
Sure thing. Let's start off by telling us how you got started as the Medication Diversion Safety Specialist.
All right. Well, a little bit about my background. I am a nurse. I was a bedside ICU nurse for 16 years in the same ICU from the time I graduated till the time I left bedside. When I did decide to retire from the bedside, I went into quality and patient safety. Worked in patient safety for a couple of years. And towards the end of that, my organization hired a consultant to come in to look at our drug diversion processes. So it was the facility patient safety consultant who escorted the diversion consultant around for a 2-day. We hit every department, perioperative areas, through the pharmacy, all of the nursing departments, anywhere that there were controlled substances. And I was so impressed that someone really focused on drug diversion. I guess 16 years in an ICU, especially in the same ICU, you get to know people so well. Obviously, diversion was occurring. And sometimes as a nurse, when you find out diversion has happened, you start to think about, what did I miss as a colleague or a peer? Maybe a little bit angry, like, hey, did I sign off a bunch of waste that person didn't waste by not following, the proper procedure? So a lot of internal questions, even as a bedside nurse. So when I saw this person who also was a nurse, really focus on drug diversion as a patient safety issue and a big concern, it really sparked an interest and I think a passion in me for drug diversion. So a few months later, when we got the report, we had about 150 recommendations. But the top 2 highest priorities were to start an official drug diversion program and to hire that person to manage the program. So I applied and went through some grueling interviews, but I was awarded the job, and I've been in this position now for 4 years. So it was actually May in 2017 that we officially kicked off our drug diversion program at Honor Health.
Very cool. Very cool. It's interesting. You touched on a topic that I think a lot of people don't really think about, and that is, if there's somebody in your unit that is diverting, they put their colleagues in a really awkward spot because they cause their colleagues to then be a part of that unknowingly, right? And it also reminds us how we need to be paying attention to what is happening to those around us. So it's something that we kind of forget about, is the impact on the colleagues, even if they don't even realize what's going on.
Right. I think it's important to remember that. And when I do education about drug diversion, I always include things like, the impression that it makes on peers, the impression that it makes on that person's leader, but also in the peer-to-peer aspect of that, ignoring those concerns is not the compassionate approach. It's not the ethical approach. What are you waiting for? For that person to be found overdosed in the bathroom, for instance, is that enough? Or, so rather catch it sooner rather than later. So that is really something that I try to impress upon clinical staff when I do education.
Absolutely. Being a nurse or being someone that's seen it or had some experience with it, it gives you a different perspective, doesn't it?
Yeah, absolutely.
So when your hospital called in the consultant, was it because there had been an event that triggered it, or just a general realization that something needed to be done?
So, if you think about the time frame, again, we started our program in 2017. The consultant came in 2016. So that time frame, there was a lot of things that were coming up in the media in general across the United States, DEA fines and all of these kind of things. So a lot of things were getting the attention, I think, in the media towards drug diversion prevention. But, when it came down to it, I think the executive sponsor and the vice president of our department just really felt like it was the right thing to do for patient safety. Let's see where we are. Let's bring a consultant in to help us, kind of really do a thorough gap analysis, basically.
Well, good for them. Number one, that they recognize that there may be a need. Number
Mhm.
two, that they took steps to find out if you did have a need. And number three, when you were given the results and it showed that, yes, there was a lot more you could be doing, that they responded to that and then
Mhm.
developed the position. So that's really cool. So, having been involved in the position from the very beginning, are there any lessons learned that you would like to share with everybody? Mistakes maybe that you made along the way, or key areas that you feel were really important, and looking back, maybe you wish you had started there or spent more time?
Yeah, there's so many. I think going back to learning what your gaps are. So we had this consultant that came in and gave us our some gaps. Like, she told us what we needed to do to get up to standard best practices. So, certainly that is a very great way to understand where your gaps are. But there's also so many resources. So I had this book of recommendations, but then, I really needed to understand on my own. So just working through a gap analysis, whether it's through, Minnesota Hospital Association, ASHP guidelines, and really reading, educating yourself, understanding where your organization is. This takes a lot of time to start meeting people, get in front of the directors of pharmacy. For me, I guess backtracking a little bit, my organization is now 6 hospitals. It was 5 hospitals at the time I started. So I had a lot of people to meet and a lot of information to gather just from, asking questions and getting to know what is the process at this facility versus maybe one of the other facilities across town. What is the history of drug diversion at your facility? What are your perspectives? Because everyone kind of thinks about it in a different manner, and has different levels of knowledge of drug diversion, and how, widespread it is or is not. There's not historically a lot of transparency, not only nationally, but even internally, between hospitals, within the hospital. So I think, understanding who your stakeholders are, your champions in each facility, and the readiness for each facility to kind of start making changes towards improving their processes is super important. But just that education and the knowledge, there's a lot of knowledge that's being shared out there. So just reading, and that self-education, just understanding the processes and then comparing what is best practice to what is really happening in the organization. You have to understand that before you can make any changes.
Yes, very true. And you're right. There are a lot of gap analysis type things out there. And if you, it's kind of goes with along with like regulations and policies. If you take the time to actually sit down and read them, you can learn a lot,
Mhm.
right? You've got to get out and implement. But then the other key piece, as you mentioned, was getting to know the stakeholders. And very important, I think, what you mentioned is what is their perception of drug diversion? Would you say that you found a lot of people in those positions that didn't have much or any knowledge, or didn't think there was a problem and kind of wondered why, you were even talking to them about it?
Sure, sure. I think so. And I think that especially goes back to that education and transparency. So, if something's happening even within the walls of a hospital, but it's never talked about among leaders, then how do you really understand the risks and what's really occurring? So I think that transparency is important in the education piece. But then just the communication. So, for instance, a pharmacy director would say, well, sometimes a manager will ask for Pyxis reports, but then I don't hear anything after that. So there was never that two-way communication of, this is what I'm concerned about, and partnering between departments to look at drug diversion, to where it's not just a nursing issue, it's not just a pharmacy issue, but they have to partner, but there has to be partnership and working on the same concerns as a team. You think HR, so this is what your diversion response team would be: executive level, nursing, pharmacy, HR, security. Everyone kind of has to work together because we all bring super different perspectives to the table. So we bring our piece of the puzzle and our talents and the things that we do well and understand as an expert. But we don't always understand each other's roles. So I think that was a big missing piece in understanding drug diversion at a facility level.
Absolutely. That partnership is very important too, because even no matter what department you're in, if you're looking at the data, that's all you see. You don't, there's a whole nother piece of it too. So the whole partnership is extremely important. Now, we've talked before, and you have mentioned that you've been involved in interviewing those suspected of diversion since the beginning of the program, right? And so let's talk about that a little bit. I know in separate conversations that we've had, we've talked about how interviewing is a skill set that both of us, I think, are working on developing for ourselves. And we also talked about how we wondered if a facility was open to the idea that if there was somebody in their facility who was addicted and diverting, if the facility was very supportive and you and I as interviewers could come right out and say, hey, come on, let's get you help. We will help you through this. That's what we're here for. And if we could be more open with them, maybe they would be more open and be willing to admit. So we've kind of talked about that. What are your thoughts on that? And is there anything that it was a while ago that we talked about it. Has there been any progress at your institution with maybe bringing that up with leadership? Anything that you can share with us on that?
So I think that this is a great conversation, and I believe a slow change that we will hopefully start seeing in the diversion community at large within our healthcare setting. Certainly, it's an ongoing conversation at a very high level at this point within my organization. But I do see the positive notes of that. So it's so hard to separate diversion as a crime, but then the person who has, potentially not only substance use disorder, but other mental illnesses and the stigma that goes along with that. So how do we respond in the right way where we're taking this seriously as a crime, because that's what it is, but we also really care about this person. So I think we have to find somewhere in the middle to really holistically respond to diversion, and not just to say, okay, we're going to terminate you and we're going to report you to the licensing board. We're going to file a DEA report. We're going to do the appropriate external reporting, but then you're just going to go off on your own. And, the likelihood of finding another job, and all of these things, just moving the problem along to another facility, another area, is probably frequently what happens. So I think that, for the community, as well as obviously for the diverter, we could respond in a better way. And I think that we will start hearing this more frequently in our community and within our networking circles.
Yeah, it's certainly something to keep in mind. I was talking to somebody just recently, and they're not in healthcare, and their response was, well, I hope that it's a crime. And it's like, yes, it doesn't mean that there wouldn't be consequences, right? There's consequences to every action. But can we do a better job of making sure that they get help? And if we can help them see and understand that the facility will stand by them if they choose to admit and to get help, and that potentially there's a better outcome after they go through that recovery phase. If it's successful, then perhaps they'd be more inclined. And then also, when, as you were talking, it made me think, right now, a lot of them do just jump to another facility, right?
Mhm.
Even before the Board of Nursing is completely aware and has conducted their investigation. So maybe another positive side of working with them and being a little bit more hand in hand is that they wouldn't tend to jump. They would not only be more inclined to get help, but it would save the next facility and whatever patients then are in their care from that too. So that's just another piece of it. And then I think we also touched upon retraining. What does the organization, what's their financial investment in every new employee? So for everyone that leaves, then we have to bring another one in. There's that financial implication. So there's actually a lot of things to kind of take into consideration, but it doesn't mean, as you said, that it wasn't a criminal act and there aren't any consequences.
Correct.
It's just a team, approach to maybe helping somebody heal, have a higher
Mhm.
probability of success on
Mhm.
that.
Correct. And I think, I'll tell you one thing that really shifted my perspective on this. And when I started in this role, obviously being in my, at this point, 18 years in my organization, I kind of at one point knew that there would be some crossing of paths, and that indeed happen. Um, and so just to put even more so of a person along with what is going on, and an understanding of, potentially understanding of the history of what is going on here, and really humanizing. And I know that we try to do that and recognize that, but that really sealed it for me, was understanding the person behind the diverter in a more personal way.
Mhm.
Really kind of changed my mind on a lot of those things, honestly.
Wow, yeah, absolutely. I didn't think about that. You're right.
Mhm,
If some
mhm,
of the staff was still there that you had thought were maybe diverting or something wasn't quite right, then yeah, your
mhm,
position then became one of, I know where to start, but then you also knew them as a human, which
mhm,
I think that's maybe one of the differences is in healthcare, we do know them as humans, right? I mean, they are dependent on drugs or alcohol, but we know them as humans. And so that does kind of change the dynamic. And, there are those that are addicted that are outside of healthcare, but we have to remember they're humans as well, right?
mhm,
And
mhm,
so they're all struggling with the same type of problem.
mhm,
So yeah, it's a lot of things to think about. And those that aren't involved in this arena at all do have a completely different view of those that are addicted or dependent on substances.
mhm, mhm.
Yeah. Okay. Well, is there anything else that you want to share or add, or did you have a question for me? Or it's
Well,
great what you're doing.
thank you. No, and I appreciate this. I don't have any specific questions, but just to say that I think it's super important for us that work in a hospital drug diversion to network and to learn from each other and to share with each other. I think that we have some really great opportunities, and we can just pick up little tidbits from what we're doing and this and that from each other, because we kind of end up siloing ourselves naturally, being usually, very few, if not one, sometimes less than one FTE at an organization to work on drug diversion. So I think this is fantastic what you're doing, to help us to share and network with each other.
That's great. Yeah. And I completely agree with you. And each time I talk to somebody or I go to a conference or listen to a webinar, somebody mentions something that either I didn't know or I had thought about, but it's been quite some time. And then you want to take it back to the organization and make sure that you're still on target with whatever that particular, thing was, that you haven't drifted away from what is best practice, and it
Mhm.
reminds you of something else that you got to check in on that you haven't maybe checked in on for a while. But yes, I think this community truly does want to see things improve and to help people, and the networking is crucial because everybody that I've come in contact with is willing to share. They don't hold it
Mhm.
to themselves. They want
Mhm.
you to learn so that you can share, and then we could make it, more transparent and even safer for all of our patients and all of our colleagues and coworkers. So,
Yes,
yeah.
yes.
All right. Well, thank you very much, Mary, for spending this time with me.
Yeah, thank you very much for having me.
Okay.